Good afternoon. Respected Dr. M.L. Swankar sir, Chairman Dr. Vikas Chandra Swankar, Dr. V.K. Kapoor sir, Dr. Andy Soni and Dr. G.S. Saxena, senior faculty members, colleagues, dear students. On behalf of Dr. V.K. Kapoor and entire UGCR team, I extend warm welcome to all of you present here to first ever UGCR. This is beginning of a new era and is a historical moment, as I have never heard any UGCR being conducted in any part of India, especially in any medical college of Rajasthan. I believe it to be only one of its kind. Our emeritus chairperson, Dr. M.L. Swankar sir, is the inspiration behind the concept of UGCR. Basically, this is brainchild of respected sir. As students and faculty, we all should feel fortunate enough to be a part of MGMCH, as we have top management with the ideology to provide best academics and growth of our students and faculty. So UGCR is for the students, by the students, and prepared by the students, moderated by one faculty, and under the guidance of subject HOD. UGCR is a platform where we will be taking one topic every time and will discuss everything from start to end regarding it, keeping in mind to include as many subject inputs in it as we can. The whole idea behind this is to teach our students to correlate the relevance and knowledge of different subjects in their MBBS course to come to conclusion in diagnosis. To begin with, a UGCR will be organized on monthly basis, but soon we might switch to twice monthly or more. Each subject involved in the main topic will be presented by one student, moderated by a moderator and guided by HOD of the subject. For example, if we take diabetes, which is a multi-system disease, multiple departments will be involved in the management and understanding of diabetes, like community medicine for incidence, prevalence, and burden, mortality, like general medicine for signs, symptoms, and management finally. So, if, for example, a subject which is relevant to the particular topic, like in diabetes, if we take general medicine as subject, we would focus on the undergraduate batch posted under general medicine. 5 students will be selected by the faculty of the department under the guidance of HOD. Out of these students, 1 student will present the seminar and other 4 will help him or her in preparing the presentation, and this shall be pattern of every department. So this enhances learning skills of the student and teach him to correlate the relevance and knowledge of different subjects, and finally to make diagnosis. It enhances clinical skills, communication skills, and how to prepare a lecture. Day and time, final day and time would be, we are going to fix a day and time according to ease of each and everyone, and that would be announced later on, the fixed date after discussion with the Dean Principal and taking into consideration the students' classes. Venue, initially we have taken this LT1 and the event is being transmitted to LT2 and outside in the gallery. Attendance will be taken batch-wise at the venue, and finally it will be added to the attendance, the main attendance of the student. Seating arrangements can be changed according to need. Front 3 rows would be reserved for the faculty members, guests and presenters. In case they are empty, the students can accommodate there. In the rows behind, rest of the students will be seated according to their batches mentioned by the signages posted on the wall. Each and every participant and contributors would be presented by a certificate, and this would be given on the next UGCR. And awards. We have kept awards also. Moderators and chairpersons and judges would assess and give marks to the presenters, and on the basis of this assessment and marks, we will choose best UGCR speaker, and the award will be given, and best UGCR group award at the end of calendar year. And this would be given on any important day as decided by the management, like on 15th August, 26th January, or annual day or convocation day. Thank you very much. This was all about the UGCR introduction, and now we'll proceed further. I would invite our Dean Principal, Dr. Andy Soni, to address the students.
Good afternoon. Honorable Dr. M.L. Swankar, Emeritus Chairperson, Mahatma Gandhi University of Medical Sciences and Technology. Respected Dr. Vikas Chandra Swankar, Chairperson cum Chancellor, Mahatma Gandhi University. Dr. V.K. Kapoor, Pro VC. Dr. G.N. Saxena sir, Dr. Swati Garg, other head of the departments, all other faculty members, and dear students. It's a matter of great pleasure that today we are having the first UGCR. You have been practicing a lot for this, and your teachers have been guiding you for this program. All of you know that medical profession is one of the noblest professions, and it is the profession of service rather than business, which has always been reminded to us by our Honorable Emeritus Chairperson Dr. Swankar sir. Your parents and your institutions are having great expectations from you, so I wish that all of you should go true to these expectations. All of you also know that for every success you have to do very hard work. Hard work is the key to the success. And always remember that the success comes before the work only in dictionary. Success comes before the work only in dictionary. So please do a lot of work, hard work. So प्रिय विद्यार्थियों, अंत में मैं यही कहना चाहूँगा, आप खूब मेहनत करें, अच्छी पढ़ाई करें, अपना नाम रोशन करें, पेरेंट्स का नाम रोशन करें, और मैं यही कहूँगा कि बेहतर से बेहतर की तलाश करो, बेहतर से बेहतर की तलाश करो। मिल जाए नदी तो समंदर की तलाश करो, मिल जाए नदी तो समंदर की तलाश करो। टूट जाता है शीशा पत्थर की चोट से, टूट जाता है शीशा पत्थर की चोट से, टूट जाए पत्थर ऐसा शीशा तलाश करो, टूट जाए पत्थर ऐसा शीशा तलाश करो। आप सभी के
invite our Pro-VC, Dr. V.K. Kapoor, to address the students.
Good afternoon.
Good afternoon, sir.
Yes. पिछली बार भी मैंने कहा था नर्सरी क्लास में जो सिखाया गया है उसको भूलना नहीं है। नर्सरी क्लास में जब मैम गुड आफ्टरनून बोलती है तो सारे बच्चे जोर से बोलते हैं ना, तो हमारे लिए तो आप लोग भी अभी भी बच्चे हो। You are all students of Mahatma Gandhi Medical College and Hospital. And I am sure even the first year students know that it is a constituent college of the Mahatma Gandhi University of Medical Sciences and Technology. I am sure there are hundreds of universities in our country, but I challenge you, you go out and find out a university where in a class for undergraduates, the emeritus chairperson of the university is present. I challenge that you go and find out a university where in a session like this, the chairperson who has 1001 things on his mind and on his phone and in his pocket or a piece of paper to do is present. You go and find out where to teach undergraduates like you, starting from first MBBS, one of the most eminent physicians of the city, who has been the principal and the pro-vice chancellor, volunteers himself to chair the session. The former principal, whose specialty is gynecology, but she is present even if the topic being discussed is the respiratory system. So you are a student of a unique institution. You should feel happy about it. You should feel proud about it. As Dr. Tarun Oja mentioned, UGCR is the brainchild of Dr. M.L. Swankar. I remember one day after the CCR, the clinical combined round, which is mainly for the faculty and residents, he called me and said that we need to start an activity which will include all students starting from first MBBS to the final MBBS and maybe interns also. Now since he is my superior, I said yes, but when I came out I was thinking about it and I was not convinced. I thought, how can there be an activity in which we involve people or boys and girls who have just joined a medical school, they are just out of the school, and interns who have gone through the entire teaching. But then gradually it dawned upon me that it is a good idea. And I'll tell you why it is a good idea. For those of you who are in the first MBBS, when we tell you are going to study anatomy, physiology, biochemistry, but we are going to tell you about pathology, pharmacology, microbiology, medicine, surgery, anesthesia. This is like a telescope. This session is like a telescope. With telescope, when you put your eye on a telescope, you can see far. You can see things which are beyond your normal vision. That is what UGCR will do for the first year MBBS students. You will be able to know. You may not understand so many things which we are going to tell you, but you would know what lies in future for you when you go to second MBBS, third MBBS. So it will be like a preview. आप लोगों की भाषा में वो movies के teaser. It is like a teaser. Okay? So sometimes teaser is better than the movie. The trailer is better than the movie. And for the final year students or even interns, I don't know how many interns are here, I made a request that interns should also join. It is like an album. एल्बम में आपकी पुरानी फोटो होती है, मेरी भी बचपन की तस्वीर है जिसको मैं आपको दिखाऊंगा नहीं क्योंकि मैं उस शेप में और पोजीशन में हूँ कि मैं दिखा नहीं सकता, तो लेकिन पुरानी यादें ताज़ा होती हैं. You remember so many things, you recollect so many things which you have forgotten, but they are important. So final year MBBS students will recapitulate what they may have forgotten or they may have it in their mind, in their hard disk, but they are not using it. It has to be revived. the anatomy, the physiology. Because as a good student, you will know that, and this is what Dr. Swarkar always says, that unless your basics are strong, your clinical acumen cannot be strong. So we have to keep remembering our basics also. And once I realized this, then it dawned upon me that the idea was useful and it should be implemented. And although Dr. Tarun said that he is welcoming everybody on my behalf, it is not that. It is purely, again, when I floated the request on the faculty group, he very promptly, very immediately responded that he is willing and going to take this responsibility, and I really thank him for creating a very dedicated group of faculty and spearheading this very important academic activity for all our students. Thank you, Dr. Tarun, for this. I will take a minute to make an appeal and request in my capacity as the Pro Vice Chancellor that you have joined to become a part of a profession, as Dr. Soni also said, which is at the top in our society and I think in any society in the world. I don't think there is any other profession which receives the same respect as we do. It might have gone down a little bit, but it is still at the top. So you have to become fit for this profession. Now you have changed from a school boy or a school girl to a medical student. And as a medical student, you are different from any other university student or any other professional student. There are so many things which I would like to tell you, but few things I would like to emphasize. One is regularity. The NMC may be 170, 80 or whatever percentage of attendance, I am not aware because I was not involved in undergraduate medical education in my previous institution. But make sure that you attend 99% of your classes. 1% for birthday, for girlfriend or boyfriend's birthday, for your parents' birthday or a marriage anniversary. I presume none of you are going to fall sick because we recently taught you how to remain healthy. Second is punctuality. Please make it a habit to be in your class 5 minutes before the class has to start. It's very easy for us to lock the doors at 9 o'clock, but we don't want to do that. We want to keep the doors open, but we want you to be in the class at 8:55. Discipline. Once you have entered the class, and this I have said earlier also, classroom is like a temple for you. आप भगवान को मानते हो या नहीं मानते हो, पूजा करते हो नहीं करते हो, लेकिन जब आपकी मदर आपको मंदिर में ले जाती है तो आप जूते चप्पल बाहर उतारते हो ना, ये तो नहीं कहते कि मैं जूते पहन के जाऊंगा या जाऊंगी. So classroom is like a temple for you. Once you have entered the classroom, once the teacher has started speaking, you have to remain quiet, no gossiping, no mobile phones. Be sincere. In this profession, even a small mistake on our part can cost the life of the patient. Try to learn as much as you can. The more you learn at this stage, the better doctor you will become, the more lives you will be able to save. और जिंदगी में अगर एक भी लाइफ बचा ली तो वो बहुत बड़ा काम है. आप तो डॉक्टर बन के पता नहीं कितनी लाइफ बचा लोगे. And last, I would say, I can assure you that the entire administration, the entire faculty of this university and this college is here only with one aim. First, yes, to make you a good doctor, but also to make you a good human being, a good ambassador of the university once you go out from here, a good Indian and a good global citizen. Welcome to the first UGCR.
Thank you, sir. Now I would invite our chairperson, Dr. Vikas Swankar, to address the students.
Thank you, Dr. Oja. Good afternoon to our Chairperson Emeritus Dr. M.L. Swankar, senior faculty members sitting in the audience, and my dear and beloved students. Since this program is for you, I would not take long because we are eager to hear the clinical material that is being presented. Allow me to congratulate the core committee members of the CCR team headed by Dr. Tarun Ojha. It's a wonderful initiative that was seeded by Dr. M.L. Swankar, and you all have so enthusiastically taken it up and sincerely working towards it. I am sure it will benefit the students. जो नया NMC ने करिकुलम प्रिस्क्राइब किया है उसमें CBME एक मेथोडोलॉजी है, करिकुलम बेस्ड कॉम्पिटेंसी बेस्ड मेडिकल एजुकेशन. तो उसमें वर्टिकल और हॉरिजॉन्टल इंटीग्रेशन की बात रहती है. वर्टिकल एज इन सपोज वी आर टॉकिंग पल्मोनरी ट्यूबरकुलोसिस, देन एनाटॉमी टू फिजियोलॉजी टू पैथोलॉजी टू मेडिसिन, रेस्पिरेटरी मेडिसिन. हॉरिजॉन्टल इज इन द सेम ईयर, जैसे आप पैथ पढ़ रहे हैं, फार्मा पढ़ रहे हैं, माइक्रो पढ़ रहे हैं, ट्यूबरकुलोसिस की. So vertical is across your professional levels and horizontal is across the subjects in the same level. So this would greatly enhance in implementing the CBME. It will help us in implementing the CBME. So जो curricular committee है महात्मा गांधी मेडिकल कॉलेज की और यूनिवर्सिटी की, kindly make a note that this has to be submitted in the regular NMC assessments as a part of our CBME programs. And as Dr. Kapoor said, this would enable you to develop a holistic approach to medicine. हो सकता है first year वाले थोड़े से बोर हों, but I am sure if you make it a point to attend each and every UGCR, then definitely you will have a better holistic point of view towards becoming a doctor. Maybe at the end of your 4th or 5th UGCR, you will definitely be more interested in this. और सर मेरा इसमें आपसे ये निवेदन है कि इसमें अटेंडेंस आप मैंडेटरी करिए. ऑल द स्टूडेंट्स हैव टू कम. दिस इज लाइक जैसे आप ब्रेकफास्ट कर रहे हैं या लंच कर रहे हैं तो UGCR में आना ही है. महीने में एक बार का कमिटमेंट है. आई एम श्योर वी ऑल कैन मैनेज 1.5 hour एवरी मंथ, नॉट अ बिग कमिटमेंट. और जो स्टूडेंट 100% UGCR अटेंड करते हैं उनको कुछ अटेंडेंस क्रेडिट्स अपने रेगुलर करिकुलम में मिलने चाहिए टू एक्ट एज एन incentive for attending UGCR. That was first. Second, you can probably take the auditorium as the venue. Though the auditorium is going in renovation from next 10-15 days for almost 1.5 months, but after that it will be at your disposal. So you can hold the UGCR, all the 5 batches including the interns, almost 1200 students would be there. They have to be there and they have to be present in the UGCR. So maybe from December onwards we can have a target of that. Also, I would like to share, as Dr. Tarun Ojha said, that the best UGCR speaker and the best UGCR team should be awarded at the important annual programs of the university. It can be the convocation, it can be 26th of January. My personal preference would be convocation, but I leave it to you to decide when is more convenient and when you want it to happen. With this, wish you all the best and thank you very much. And जैसा कपूर साहब ने बोला कि मैं as a chairperson यहाँ पर हूँ या मेरे father as chairperson emeritus यहाँ पर हैं. ठीक है, we hold those positions in the university, but we are here as your senior colleagues, guides, teachers, and it is our privilege to be amongst you and attend this program rather than other way around. Thank you for having us.
Thank you, Dr. Vikas. Now I would invite our Emeritus Chairperson, Dr. M.L. Swankar sir, to bless us on this occasion.
सबसे पहले तो मैं डॉक्टर कपूर साहब को धन्यवाद देना चाहूँगा कि आपने ये जो इनिशिएटिव दिया UGCR का शुरू किया मेरे अनुरोध पर. In fact, this idea came to me when I was visiting my friend about 20 years back, thinking King's Medical College. So there is integrated teaching, vertical and horizontal going on. So Dr. Ananda, who is a Queen's Medical College. He's Professor of Orthopedics. He said that why are you not starting this? Because we need a lot of anatomy, physiology, diagnostic in first MBS. We do not bother for other subjects. Then we try to forget these things, and in the second MBS we go for the pathology, pharmacology, and then final MBS. That is also very good system. But if you combine both vertical as well as horizontal, and especially for the children who are here, first MBS, second MBS, and MBS, if you have both systems together, then they will have very good foundation. तो किसी भी लाइफ में अगर आपको कुछ अचीव करना है, तो आपके बेसिक्स, आपके फाउंडेशन बहुत स्ट्रॉन्ग होनी चाहिए. अगर आपके फाउंडेशन स्ट्रॉन्ग हैं, तो फिर आप एक अच्छे डॉक्टर बन सकेंगे और सोसाइटी की अच्छी सर्विस कर सकेंगे. मेरा या सीनियर फैकल्टी यहाँ बैठी है, हमारा इस सारे एकेडमिक एक्टिविटीज़ के पीछे जो भाव है वो माता पिता जैसे सब आप हमारे बच्चे हो, बेटा बेटी हो. आपकी हम फाउंडेशन स्ट्रॉन्ग करें, यहाँ से निकल के जाएँ तो आप एक अच्छे डॉक्टर बनें, अच्छे क्लिनिशियन बनें, अच्छे इंस्टीट्यूशन में सेलेक्ट हों, पोस्ट ग्रेजुएशन करें या अच्छी प्रैक्टिस करें. इसलिए हम जितने भी बेस्ट एफर्ट्स हैं, चाहे UGCR है, चाहे PGCR है, या कम्बाइंड रीजनल राउंड्स हैं और भी इस तरह की एक्टिविटीज़ हैं, उसका जो टास्क डॉक्टर कपूर ने मेरी रिक्वेस्ट किया है, तो मैं चाहूँगा कि आप इसमें बड़े दिल से भागीदारी निभाएं. इट इज़ गोइंग टू, और सबसे जो एक इम्पोर्टेंट बात इसमें ये भी है कि जो कॉमन डिसऑर्डर्स हैं, कॉमन डिजीज़ हैं, जैसे आज ट्यूबरकुलोसिस किया है, इस दिन जॉन्डिस लेंगे, इस दिन डायबिटीज़ लेंगे, जो आपको डेली आपकी क्लिनिकल प्रैक्टिस में काम है, तो उनकी आपके फंडामेंटल बहुत स्ट्रॉन्ग होते हैं. यदि आप पासिंग मार्क जैसे कहते हैं ना, वही आपने टॉप में किया और आपने पासिंग मार्क, आपको कॉमन चीज़ों का डायग्नोसिस आता है, तो काफ़ी कुछ आप लाइफ में सब कर सकते हैं. These words, I request all of you to attend, as told by our chairperson, Dr. Vikas Sonkar, that be regular, make the attendance 100% compulsory. It should be from your own, sort of thing. ठीक है ना, इसमें दूसरे को कहने की आवश्यकता, आपने खुद में इंस्पिरेशन होना है, मुझे इसमें जाना है, सीखना है. फर्स्ट MBS वाला क्या बोल रहा है एनाटॉमी फिजियोलॉजी के बारे में, दूसरा पैथोलॉजी ईटियोलॉजी के बारे में क्या बोल रहा है, फार्माकोलॉजी वाला ट्रीटमेंट के लिए क्या बोल रहा है, क्लिनिशियन है वो क्या बोल रहा है, PSN वाला इसका पूरा ओवरऑल सोसाइटी में क्या दिखा रहा है, इस तरह की प्रॉब्लम है सोसाइटी की. ये सारी चीज़ें हैं और मेरे हिसाब से अगर इसको प्रॉपरली इम्प्लीमेंट कर दिया तो इट विल बी वेरी गुड थिंग. एंड आई विश यू ऑल द बेस्ट एंड माय ब्लेसिंग्स. Thank you.
So now we are going to start our first UGCR. The topic is pulmonary tuberculosis, and it will be taken in two parts. Part 1 is being done today, which includes Department of PSM, Anatomy, Pathology, Microbiology, and finally open discussion, question answers, and question answers. So I would invite the presenter from Department of PSM, Introduction and Burden of Tuberculosis.
Good afternoon, Excellencies, esteemed guests, professors, and my fellow good friends. I extend my warm greetings over this first undergraduate combined clinical round. My team, Gaurav Soni, Vijul Agarwal, Gaurav Agarwal, Mihika Chaparwal, and myself, Shivangi Sharma from second year MBBS, batch 2021, representing the Department of Community Medicine under the guidance of Dr. Rajat Vora Sir, Professor and HOD, and moderator Dr. Neeti Gehlot Ma'am, Associate Professor. And we are going to talk about what is tuberculosis and burden of tuberculosis. Tuberculosis is a chronic infectious disease caused by Mycobacterium tuberculi, which primarily affects lungs and characterized by asymptomatic infection or may present with signs and symptoms that are often non-specific and insidious, consisting mainly of prolonged cough, fever, night sweats, weight loss, anorexia, general malaise, and weakness. Extrapulmonary involvement is seen in few cases known as extrapulmonary tuberculosis. Here we can see the pulmonary involvement is 79% and extrapulmonary involvement is 21%, in which majority is of lymphatics, that is 32%, followed by pleural, that is 27%, and bones and joints 11%. The source of infection is humans with active tuberculosis who transmit mycobacteria into the air, like by coughing. TB is present in all countries and it affects all the age groups, but TB is curable and preventable. If we talk about burden of tuberculosis, tuberculosis is the top killer in the world from a single infectious agent. In 2021, 1.59 million people died across the globe, including 1,87,000 people with TB/HIV. TB is the leading killer of people with HIV and a major cause of death related to antimicrobial resistance. As per Global Tuberculosis Report 2022 by WHO, here we can see the global burden of TB. Total TB cases, there are 10.6 million. Children with TB, 1.2 million. Death due to TB, 1.6 million. And drug resistance to TB, 0.5 million. Here is a global estimate of TB incidences according to age and gender 2021. Here we can see it is higher in males as compared to females, and it affects more commonly the people who are in age group of 15 to 45 years. As per India TB report 2021, we can see incidences globally 127 per lakh, in India 188 per lakh. HIV negative TB mortality 17 per lakh globally, and in India 36 per lakh. HIV positive TB mortality 2.7 per lakh globally, and in India 0.78 per lakh. HIV TB cases 10 per lakh globally, and in India 3.8 per lakh. If we talk about global percentage, incidences 26%, HIV negative TB mortality 38%, HIV positive TB mortality 5%, and HIV TB cases 7%. As per National TB Prevalence Survey 2021, here is the state-wise prevalence of pulmonary TB, in which we can see highest prevalence of TB is in Delhi, that is 534, and prevalence of TB in Rajasthan is 484. Here we can see the global trend in case notification of people newly diagnosed with TB from 2015 to 2021. Here we can see there is a dip in year 2020 which corresponds to the COVID-19 restrictions, but after that we can see that there is gradual rise in number of notified cases again in 2021 as due to upliftment of COVID-19 restrictions. Now I would like to invite my fellow colleague from Anatomy department to continue this further.
Good morning to all the respected dignitaries, our esteemed professors and my fellow colleagues present here. I, Praveen Kaur, I am from batch 2022 MBBS and I am here to present our topic Applied Anatomy of Respiratory System on behalf of my team, which includes Pratyush Agarwal, Mansi Mehla, Aru Jain, Diya Sethi and me, Praveen Kaur. We have had the privilege of working under the guidance of Dr. Jagmohan Sharma and Dr. Abhilasha Maharishi. First, I would like to give you an overview of the respiratory system. The respiratory system on the basis of structure is divided into the upper respiratory tract and the lower respiratory tract. The upper respiratory tract consists of the nasal cavity, the pharynx, the part of the larynx which is present above the vocal cords, and the lower respiratory system consists of the part of the larynx present below the vocal cords, the trachea, the bronchi, the bronchioles, and finally the lungs. On the basis of structure, the respiratory system is divided into the conducting part and the respiratory part. The conducting part helps in the transport of the air and the respiratory part carries out the gaseous exchange. The respiratory part consists of the respiratory bronchioles, the alveolar duct and the air sacs known as alveoli. This is the upper respiratory tract. The air enters the nasal cavity. Here elevations are present in the nasal cavity that are the superior concha, the middle concha and the inferior concha. These are present to increase the surface area of the nasal cavity for humidification and purification of air. From there, the air enters the nasopharynx. From nasopharynx to the oropharynx, which extends up to the level of C6 vertebrae. From there, it enters the trachea, which is guided by a cartilaginous flap, that is epiglottis. The lower respiratory tract then consists of trachea, which divides into two primary bronchi, which further divides into secondary bronchi, then tertiary bronchi, and then gives terminal bronchiole, respiratory bronchiole, alveolar duct and alveoli. Now this upper part, which only helps in the conduction of air, is the conducting part, and this lower part, which helps in the gaseous exchange, is the respiratory part. We'll come to the development of the respiratory system. The development starts when a lung bud arises from the foregut, and the connective tissue is formed of the splanchnic mesoderm. It starts in the 4th week. The laryngotracheal groove appears in the floor of the pharynx. The tracheoesophageal groove deepens to form a laryngotracheal tube, which grows down caudally and it bifurcates to give two lung buds. In this diagram here, we can see this is a lung bud arising from the gut tube. It grows down caudally and it is present ventrally. It consists of endoderm, which is here shown in green color, and also a splanchnopleural mesoderm, which is here shown in pink color. The gut tube and the trachea is connected. To separate it, a tracheoesophageal septum is formed. If there is failure in the formation of this septum, it leads to a congenital anomaly, that is the tracheoesophageal fistula. After that, we come to the fate of the lung bud. The proximal part forms the larynx and the distal part forms the trachea. The splanchnic mesoderm gives rise to the surrounding connective tissue. Let's come to the maturation of lungs, which includes 4 stages. The first is the pseudoglandular stage. In pseudoglandular stage, the bronchial bud gives the right and the left secondary bronchi. 3 on the right hand side corresponding to the 3 lobes of the right lung, and 2 on the left side corresponding to the 2 lobes of the left lung. It consists of the cuboidal epithelium, as we can see here in this diagram. Cuboidal epithelium is also known as glandular epithelium, and that is why the name of this stage is pseudoglandular stage. The next stage is the canalicular stage. As the word suggests, it leads to the formation of canals. From the terminal bronchioles, the respiratory bronchioles form. From them, the alveolar duct, and there is also vascularization of the surrounding mesenchyme. That is, there is formation of the pulmonary capillaries. Then is the saccular stage, which includes the development of alveoli. There are type 1 pneumocytes which are formed. These are the flat cells which helps in the gaseous exchange, and also type 2 pneumocytes are present which release the surfactant. Surfactant is a substance which decreases the surface tension and prevents the alveoli from collapsing. The alveolar stage, in this stage there is increase in the number and size of alveoli and the respiratory unit grows. The breathing movement before birth is not continuous and it increases as the time of the delivery approaches. This helps in the conditioning of the respiratory muscles. At the time of birth, the lungs are half filled with amniotic fluid, but at the time of birth, they are cleared because of the pressure on the fetal thorax during delivery and also by the absorption of pulmonary capillaries and lymphatics. The lungs of a newborn, if these are the healthy lungs, they always contain air and they float in water. If they are diseased, they may contain some amount of fluid and they won't float in water. If the lungs are of a still pond, they will be firm, it will contain fluid and it will sink in water. The gross anatomy of lung. On right hand side, the right lung consists of 3 lobes, the superior lobe, the middle lobe and the inferior lobe, separated by horizontal fissure and oblique fissure. On the left hand side, there are 2 lobes, the superior lobe and inferior lobe separated by an oblique fissure. Sometimes the azygous vein, rather than crossing above the apex of the lung, it penetrates the apex of the right lung and leads to the formation of an extra lobe, that is the azygous lobe. Now this lobe is not functional because it doesn't have its own blood and nerve supply. The apex of the lung, the relations are important to know of the apex of the lung. Anteriorly it is related to the subclavian vessels, the subclavian artery and the subclavian vein. It is also covered by Simpson's fascia. It is a fascia which extends from the transverse process of C7 vertebrae to the inner border of the first rib. Posteriorly, it is related to the neck of the first rib and structures related to it which are sympathetic chain, first posterior intercostal vein, superior intercostal artery, and ventral ramus of T1 nerve. The hilum of the lung. It is a point from where the various structures enter and exit the lungs. The various structures are pulmonary arteries, pulmonary veins, bronchi, and some lymphatics. Carina is a key-like cartilaginous ridge which is present at the point where the trachea divides into two principal bronchus. It runs antero-posteriorly and is present here. The right bronchus is broad and is straight, whereas the left bronchus is oblique and narrow. That is why the right lung is more prone to having invaded by any foreign body and more prone to infections. At the time of bronchoscopy, any narrowing or displacement of the carina can indicate tuberculosis or cancer. Also, the epithelium of carina is very sensitive and gives the cough reflex. The bronchopulmonary segment. These are well-defined wedge-shaped sectors in the lungs. They are aerated by the tertiary bronchus, and they have their own blood supply, which is by the pulmonary artery, and their venous supply, which makes them an independent functional unit. 10 bronchopulmonary segments are present on each side, the left hand side and the right hand side. The knowledge of bronchopulmonary segment has led to an advancement in the lung surgery. Mostly, many chronic diseases such as tuberculosis are localized to a particular segment. So the surgeons can easily remove a segment which is infected, keeping the rest of the lung intact. It can be pneumectomy, which is removal of the entire lung. It can be segmentomy, removal of a specific segment, wedgectomy, removal of a wedge-shaped base, and lobectomy, removal of the lobe of the lung. We'll come to the anatomy of pleura. It is a bilayered serous sac. There are two layers of the pleura, the visceral pleura, which is closely adherent to the lung, and the parietal pleura, which is the outer pleura. Recess of pleura. It is the reserved place which is present between the two pleural layers, and it helps in the expansion of the lung during deep inspiration. As we can see here, this is the costodiaphragmatic pleura. So costodiaphragmatic recess, which is between the costal pleura and the diaphragmatic pleura, and here is the costomediastinal recess. Sometimes there is abnormal collection of fluid in the pleural cavity, which is known as pleural effusion. And in pleural effusion, costodiaphragmatic recess is the most dependent part. And to aspirate this fluid, the aspiration is done from the 9th intercostal space in the mid-axillary line, as we can see here in this diagram. And this process is known as paracentesis thoracis. Pneumothorax is the accumulation of air in the pleural cavity. The TB bacteria invades the pleura. It causes necrosis, which is tissue death, because of which there is rupture of pleura. There is communication between the atmospheric air and the pleural cavity. With each inspiration, the air enters the pleural cavity and leads to pneumothorax. The microanatomy of alveoli is important because this is the place where the TB bacteria acts. The epithelium of alveoli consists of the T1 pneumocytes, which are flat cells which helps in the gaseous exchange, and type 2 pneumocytes, which release the surfactant that decreases the surface tension and prevent the alveoli to collapse. Macrophages, as we can see here, are present in the lining of the alveoli, which fights the tuberculosis causing bacteria. There is a respiratory membrane which acts as an air-blood barrier, which is between the air and the capillaries of alveoli, and the diffusion of carbon dioxide and oxygen takes place through this membrane. It consists of the epithelium of the alveoli, the epithelium of the capillaries, and the fused basement membrane in between. The lymphatic drainage is the superficial plexus drains into the bronchopulmonary nodes which are present at the hilum. The deep plexus drains into the pulmonary nodes, and finally it drains into the tracheobronchial nodes, and finally into the mediastinal lymph trunk. Tuberculosis, the pulmonary tuberculosis is an infectious disease which is caused by Mycobacterium tuberculi. It can be primary infection. Primary infection mostly happens in children, and there is no particular site of primary infection. Sometimes the infection is not completely eliminated and remains in a latent phase. There can be secondary activation or reactivation known as the active stage of bacteria. The places in the lungs or the site in the lung which are more prone to active infection are apex of the lung, the posterior part of the upper lobe, and the upper part of the posterior lobe. When the bacteria enters, it is attacked by the macrophages, and with T lymphocytes it forms a granuloma which can be seen in the radiograph, and it is the first indication of the infection. It is known as gone focus, and the gone focus along with the regional lymph nodes forms the gone complex which can be easily detected in a radiograph. Here we can see this is a gone focus, and in this radiograph this opacity shows the gone focus. Consolidation in the lung. It indicates the filling of the alveoli and bronchioles in the lung with pus, fluid, blood or neoplastic cells, as we can see in this radiograph. Hilar enlargement is also a symptom of pulmonary tuberculosis, which is the enlargement of the lymph nodes in hilum. It could be due to other reasons such as drug reactions, carcinoma. Pain in lung disease. Now the lung tissue and the visceral pleura are devoid of pain-sensitive nerve endings. Pain in the lung can be a result of when the infection has affected to the parietal pleura. The costal parietal pleura is innervated by the lower 5 intercostal nerve, and it also innervates the anterior abdominal wall. That is why the pain sometimes gets referred to the abdomen. Also, the diaphragmatic pleura is supplied by the phrenic nerve with nerve root C3, C4 and C5. And the shoulder is supplied by supraclavicular nerve C3, C4. Because of the same nerve roots, sometimes the pain is referred to the shoulder also. This brings us to the end of the presentation. Now I would request my fellow colleague to continue with the presentation from the Department of Pathology.
Respected dignitaries, faculty members and my fellow colleagues, a very good afternoon to all of you. I would like to extend a very warm welcome to all of you on behalf of Department of Pathology. Starting with introducing my team members, Divyanshi Chauhan, Rakshit, Khushi Khandelwal, Mansi Mishra and myself Khushi Sharma. Belonging from 2021 batch under the guidance of Professor and Head of Pathology Dr. Manju Raghav, Assistant Professor Dr. Neeraj Goyal and Associate Professor Dr. Chetna Mehrod would like to represent the pathological basis of tuberculosis. Starting with a quick overview, we all know that tuberculosis is a chronic pulmonary and systemic disease, and it is a leading cause of death worldwide. According to the WHO statistics, approximately 3 to 4 deaths per minute occur due to TB worldwide. So by the time it takes you to listen to this presentation, about 45 people around the world would have lost their life to tuberculosis. Starting with a quick overview, Mycobacterium tuberculosis is highly aerobic, belonging to family Mycobacteriaceae. It is an acid-fast bacilli, so it can be stained by Zn staining or Z nasal staining, where it appears as red-colored and rod-shaped bacilli. Talking about the transmission, we all know that tuberculosis is an airborne disease. So it transmits to droplet infection. The droplets released by host basically enter, the droplets released by the active case of TB basically enters the host by means of droplet infection. The bacteria enters the body of the host and traverses the nasal passage, the upper respiratory tract, the bronchi, and finally reaches the alveoli of the lungs, where it starts its pathogenesis, which is the main topic of concern today. The outcome of infection in a previously unexposed immunocompetent individual depends on the development of antimycobacterial T-cell mediated immunity. And it is this Th1 response only which is responsible for the formation of pathological lesions, namely cacheating granulomas and cavitation. The infection proceeds in steps, the first step being the entry of the bacteria inside the macrophage, which is facilitated by phagocytosis. The alveolar macrophage expresses certain kind of receptors known as mannose receptors, complement receptors 3 or type A scavenger receptor. The bacteria then enters inside the macrophage and gets temporarily stored in a membrane-bound vesicle known as phagosome. So under normal condition, phagosome basically combines with lysosome and forms a complex called phagolysosome, which eliminates the bacteria. But that does not happen in case of infection. So what actually happens in the case of infection is the bacteria induces phagosomal manipulation, which we will discuss in detail later on. So, as a result, the manipulated phagosome will not be able to kill the bacteria, which will result in unchecked bacillary proliferation. So, in the early stage of primary tuberculosis, we can see bacteremia and seeding at multiple sites, that is increased bacterial load in the blood, which can infect other organs also. Starting with the phagosomal manipulation, the first point is ineffective phagolysosome fusion. So inside the membrane of phagosome, there is a signal transduction pathway called calcium carbonyl pathway. Let me explain this to you all in a very simplified manner. Calcium acts as second messenger. It binds with a protein called calmodulin. Calmodulin gets activated and which modifies the interaction of calcium with various target proteins called kinases and phosphatases. But then comes into picture a mycobacterial cell wall protein called lipoarabinomenin. On the right side of the screen you can see the mycobacterial cell wall and you can spot lipoarabinomenin here. It is a heat stable protein. What it does, it actually inhibits the intracellular increase in calcium. So as a result there is impaired calcium carbonyl pathway, inhibition of phagolysosome fusion, and at the end the bacteria survive inside the phagosome. But this is only one pathway. Apart from this pathway, there are several other pathways by which the bacteria can prevent the fusion. The one being decreasement of a protein called coronin, which is basically a host protein. It activates an enzyme phosphatase calcium urate, which prevents the fusion. On the other hand, if you all can recall, there is an enzyme called phosphatidyl inositol 3-phosphate. It is the component of the host cell membrane, which is required for the sorting and maturation of phagosome. By inhibiting this enzyme, there will be no sorting and maturation, and thus the fusion will be prevented. The second point in manipulation is maturation arrest by lack of acidic pH. Normally, in order for phagosome to mature, acidic pH is required. So for that, they have an enzyme called vacuolar ATPase enzyme, whose function is to pump the protons inside to provide the increased acidity for its maturation. But that does not happen in case of infection. Why? Because Mycobacterium tuberculosis will release a protein called protein tyrosine phosphatase, which will inhibit this enzyme, and as a result, there will be no diffusion of protons inside and no acidification, and at the end, no maturation of phagosome. Lastly, inhibition of interferon production. So there is a molecule inside the cytoplasm of phagosome known as cyclic GMP-AMP synthase. Its normal function is to detect the foreign dsDNA, activating a STING pathway and release interferon. But as we all know that the phagosome now is manipulated, it will not lyse. So as a result, the C gas will not be exposed to the bacterial dsDNA. The STING pathway will not get activated, and at the end, interferon production will not take place. As we all know that innate immunity is the first line defense against any invading pathogen. So in this case also, the Th1 response will be mounted approximately 3 weeks after the infection. But what are those factors that will lead to the activation of this immunity? The first factor is pathogen-associated molecular patterns. These are released by the bacteria itself and will be recognized by immune receptors like toll-like receptors 2 and toll-like receptors 9. Also, we all know that dendritic cells in our body are the antigen-presenting cells, and they will present these antigens to the draining lymph nodes. As a result, the T cells will get activated, and I would like to draw attention to this point that CD4 cells produce interferon gamma, which acts as a key mediator that activates the macrophages. This Th1 response is basically used in the screening of tuberculosis. The test is known as tuberculin skin test. In tuberculin skin test, what we do is we inject 0.1 ml of PPD, that is purified protein derivative, intradermally into the host. As a result, the delayed type 1 hypersensitivity reaction occurs inside the host, which basically manifests as a visible and palpable induration. If the diameter of this induration is greater than 10 mm, then it indicates positive test for the result. As I said earlier, that interferon gamma is the key mediator. So what is its role in the pathogenesis? The first is the stimulation of phagolysosome formation, which was earlier inhibited by the bacteria. Secondly, stimulation of expression of nitric oxide synthase. So if nitric oxide synthase gets stimulated, there will be release of inducible nitric oxide, which is lethal to the bacteria. Third is mobilization of defenses against the bacteria, and at the last, stimulation of autophagy. All these factors basically contribute to contain the infection and prevent its spread further. As we all know that tuberculosis comes under the category of chronic granulomatous inflammatory disease. So at the end of this disease, there is significant tissue damage and granuloma formation. The macrophages which were activated previously by the interferon gamma differentiate into epithelioid histiocytes. These histiocytes further aggregate to form giant cells. Also, these activated macrophages secrete tumor necrotic factor and chemokines, which recruit monocytes at the site of infection, which further creates tissue destruction. This is the microscopic picture showing granuloma. So in the center, you can appreciate caseous necrosis, which appears as homogeneous, amorphous, highly granular, and highly eosinophilic material. This is rimmed by epithelioid macrophages, which have slipper-shaped nuclei, and among them we can also find multinucleated giant cells having horseshoe-shaped nuclei located at periphery. At the periphery of the granuloma, there are lymphocytes and plasma cells. Now coming to the stages of tuberculosis. Tuberculosis can exist as a primary infection, as a latent infection, and can even progress into an active disease. So starting with the primary infection, the bacteria basically thrives in the area of high oxygen tension, which is basically the apex of the lung, because the apex of the lung is associated with high ventilation perforation ratio. The caseation takes place, and if it involves the regional lymph nodes along with it, then it leads to the formation of a complex known as Bowen's complex. This primary complex can further progress into primary TB and can undergo massive hematogenous dissemination, which can involve liver and spleen, known as miliary tuberculosis. But in case of 90 to 95% of the patient, these lesions exist as latent lesion in which the bacteria exist as dormant. It is a clinically asymptomatic disease. This latent lesion can also progress further and cause secondary tuberculosis. But for this reactivation of bacteria, immunosuppression basically plays a major role. Immunosuppression can be seen in the case of HIV infection, in the patient receiving TNF-alpha inhibitors, and in case of post-transplant immunosuppression. As we all know that TNF-alpha inhibitors are included in the pharmacotherapy for the patient of rheumatoid arthritis. So in those patients, there is high chances of reactivation of TB. I would like to throw light upon the HIV infection here. As said by my colleague earlier, that there is increased risk of infection in case of HIV because of immunosuppression, but that immunosuppression is basically caused by CD4 plus cell count. This CD4 plus cell count reduction is very low in case of HIV, which is the hallmark of HIV, and it interferes with the protection mechanism from the bacilli. Lastly, we know that TB is a preventable and curable disease, but approximately 1.59 million of deaths occur globally. So the fight against the TB should not only be a scientific endeavor, but a human one. Together we can make a difference. This brings me towards the end of my presentation. Now I would like to invite my fellow batchmate, Disha Maskara, to continue on the microbiological aspect of TB.
A very good afternoon to all the respected dignitaries, faculty members and my fellow colleagues. Today, our group of 5 members, Lakshay Sharma, Garvit Mittal, Ananya Tang and Prachi Bansal and I, Disha Maskara from the batch 2021 are here to give a presentation on the topic Etiology and Laboratory Diagnosis of Pulmonary Tuberculosis. So, these are non-motile, non-sporing, non-capsulated, straight or slightly curved, broad-shaped bacteria. These are obligate aerobes. But the most characteristic feature of mycobacteria is acid fastness, that is, they are acid fast and alcohol fast, which means they resist decolorization by 20% sulfuric acid and absolute alcohol. This is due to the presence of high content of mycolic acids in the cell wall and integrity of the cell wall. Taking a look on the cell wall, as we can see, the cell wall is made up of distinct layers. These distinct layers are responsible for providing characteristic features to the bacteria. The first layer is the peptidoglycan layer, which is responsible for the structural component and maintenance of the rigidity of the cell wall. The second layer is the arabinogalactan layer, which is responsible for the structural component of the cell wall. The principal constituent of the cell wall is the mycolic acid layer, as it confers very low permeability to the cell wall and it makes the cell wall resistant to most of the antibiotics, making the treatment ineffective with normal antibiotics. Coming on to the diagnosis of pulmonary TB. The diagnosis of pulmonary TB is done mainly on the basis of combination of clinical features, radiology and laboratory diagnosis. So talking about the microbiological diagnosis of pulmonary tuberculosis, for making an accurate diagnosis, the collection of an appropriate sample is needed. So in pulmonary tuberculosis, sputum sample is collected. For precise diagnosis, collection of 2 sputum samples is recommended. One sample is collected when the patient visits the doctor and the doctor suspects the patient to be a TB patient, presumptive TB patient. Then the sample is collected on the spot under supervision and the next sample is collected the next early morning. Other samples include the gastric aspirate, which is done in children. Other less common methods include bronchoalveolar lavage, which is done in smear-negative pulmonary TB cases. For the right sample collection, the patient is advised to follow few steps. Here we see the list of those steps. So if we discuss these steps, first the patient is advised to drink a lot of water before bed and then rinse the mouth with filtered water the next morning. Then the patient is instructed to take deep breaths 2 to 3 times and then inhale hard and then produce sputum. To produce sputum, then the sputum is collected in a sterile container. Talking about the quality and quantity of the sputum collected should be 3 to 5 ml in quantity and it should be purulent and thick. Now after the sample is collected, we come on to the microbiological diagnosis of pulmonary tuberculosis. It is done using these 3 diagnostic tools. As we can see, the first is the sputum smear microscopy, which includes the Zeal-Nielsen staining and the fluorescence staining. The second is the culture techniques. This includes the solid culture media and the automated liquid culture system. The last method are the molecular methods, which includes the nucleic acid amplification test. In this we have 2 systems, the CV-NAT and the TrueNAT. The second molecular method is the line probe assay. Coming on to the sputum smear microscopy, here we see the image of the sputum smear microscopy. As we can see in the first image, the ZN stained sputum smear shows long, slender, beaded, red-colored bacilli against a blue background under the light microscope. Whereas in the second image, we can see brilliant, bright green-colored bacilli against a dark background under the fluorescence microscope. In this, we use the auramine rhodamine stain. Now, the NTEP guidelines for grading of ZN stained sputum smears are useful. And we see in this number of AFP in 100 oil immersion fields. If 100 oil immersion fields to be screened, then the result is negative. If we see 1 to 9 bacilli per 100 oil immersion fields, 100 fields to be screened, then the grading is scanty. If we see 10 to 99 bacilli per 100 oil immersion fields, again 100 fields to be screened, then the grading is 1+. If we see 1 to 10 bacilli per oil immersion field, 50 fields to be screened, then the grading is 2+. If we see more than 10 bacilli per oil immersion field, 20 fields to be screened, then the grading is 3+. These guidelines for grading of ZN stained sputum smear are useful in monitoring the treatment response of the patient. It is also useful in assessing the severity of the disease, assessing the infectiousness of the patient. Higher the grade, more is the infectiousness. In comparison, smear-negative patients are considered less infectious. On comparing the advantages and disadvantages of smear microscopy, the advantages include the fact that we get same-day results. It is a simple technique and is inexpensive and widely available. It can be used for treatment monitoring, whereas the limitations include its low sensitivity. It is not accurate for children and people with HIV. It can't distinguish MTB from non-TB mycobacteria. Talking about the culture techniques, which is the second diagnostic tool, these are the gold standard methods for the diagnosis of pulmonary tuberculosis. In this, first we have the solid culture method, which uses the Lowenstein-Jensen media, which is an egg-based media. In this, the bacterial growth time is of around 6 to 8 weeks. Here we see the rough, tough and buff colored colonies of the mycobacteria. Coming on to the second culture technique, which is the automated liquid culture method. It uses the Mycobacterium growth indicator tube system. The media used here is the middle group 7H9 media. Here we see the granular microcolonies of the mycobacteria. Here the growth time is of around 2 to 3 weeks. Now, if we compare the advantages and disadvantages of culture techniques, the most important advantage of culture technique is that drug susceptibility test can be performed. Other advantages include it is used for both pulmonary and extrapulmonary TB samples. It is also used to monitor response to therapy and long-term follow-up of drug-resistant TB cases. Its limitations include the fact that it is prone to contamination, requires stringent quality assurance systems, it is expensive, and there is requirement of well-trained staff with extensive technical expertise. Lastly, we have the molecular methods. In this, first we discuss the nucleic acid amplification test, which have the two systems, CB-NAT and the TrueNAT. In cartridge-based nucleic acid amplification test, the sample is inoculated in the cartridge and then the cartridge is inserted into the machine. We get the result within 2 hours. Whereas in the TrueNAT, which is also known as the chip-based nucleic acid amplification test, the sample is inoculated in the chip and then the chip is inserted in the machine. Here also we get the results within 2 hours. Now if you compare the advantages and limitations of NAT, then it has better sensitivity and specificity as compared to the culture techniques and smear microscopy. Here we get the rapid results and we do not require any technical expertise. Most importantly, rifampicin susceptibility test can also be performed, whereas its limitations are it is expensive and DST cannot be done for all anti-tubercular drugs. It is not advised for follow-up of cases. Here we come to the second molecular method, which is the line probe assay. The line probe assay includes the probe-based detection of the amplified DNA. It has 2 steps. In the first step, the DNA is amplified using the PCR method, whereas in the second step, the amplified products are hybridized on the nitrocellulose strip, which is used to detect specific antigens and which is coated with specific probes. In this, we see the band formation on the strips. Now, the clinical interpretation of the LPA results is that, for example, we have the rifampicin drug which uses the RPOB gene. If the RPOB gene appears on the strip, then the mycobacteria is rifampicin resistant and we cannot give rifampicin in the treatment. Similarly, we can do it for other similar drugs also, anti-tubercular drugs. Now coming on to the advantages of line probe assay, it is a quick method. We get the results within 48 to 72 hours. It can be used to detect the resistance to first line and second line drugs, making it a guiding tool for the treatment decisions in MDR and XDR cases. Its limitations include it can be done only on smear positive specimens, it is expensive, it requires well-trained staff in a professional laboratory and has high biosafety requirements, which makes it unavailable at several places. Now this is the algorithm provided by the NTEP for the correct diagnosis and management of TB cases. So let's consider a scenario: a patient visits the doctor and based on the clinical features, the doctor assumes the patient to be presumptive TB patients. Then 2 tests are performed. One is the smear examination, another is the chest X-ray examination. In the first scenario, if the patient's smear examination is positive, regardless of the chest X-ray report, then the patient is a case of microbiologically confirmed TB. Now, in the second scenario, if the smear examination is negative, but chest X-ray report is suggestive of TB, or the smear examination and chest X-ray report are negative, but the patient is of high clinical suspicion, then we perform the CB-NAT. On the basis of CB-NAT results, if MTB is detected, we go on to perform rifampicin susceptibility test simultaneously. If the patient is rifampicin sensitive, then the treatment goes on as planned, but if the patient is rifampicin resistant, we refer the patient to management of rifampicin resistant. Now, if the CB-NAT results show MTB not detected, but the clinical suspicion is high on the basis of clinical features, then the patient is treated as the clinically diagnosed TB case. Concluding, we can say that TB diagnosis requires a combination of different methods and techniques for accurate diagnosis. There is no single TB test that can do it all. Culture remains gold standard for the definitive diagnosis of TB because drug susceptibility test can be performed and it is used for monitoring treatment response or follow-up of cases. Molecular methods like the nucleic acid amplification test and the line probe assay are promising tools with a very low turnaround time and higher sensitivity. Thank you.
Wonderful presentation by all the students. Now we move on to the question answer round. So I'll invite all the participants and contributors on the stage. Please do come. And finally we'll have concluding remarks from our Pro VC, Dr. V.K. Kapoor sir. And audience, if there is any question. Sir.
I have a question to the community medicine team. I know you may not be able to answer, so then your teachers will come to your rescue. In one of the slides, you said that in HIV negative cases, Indian mortality is higher than global. But in HIV positive cases, you said Indian mortality is less than global mortality. What is the reason for that? Are we doing very good? No, but the mortality rate also was shown to be less than the global mortality of HIV positive TB. So for the students, this combination, in one of the slides, the student presented that it is a double trouble. Any patient who has HIV and tuberculosis both is a very serious situation, because HIV causes the immunity to be low. And the immunity is low, so infection will behave more aggressively. So it's a very dangerous combination, and actually it is a problem in Africa, sub-Saharan Africa, where HIV is much more common than us. But I was surprised to see that our mortality in that subgroup.
Though tuberculosis is the most common opportunistic infection in HIV, African countries have a higher burden of HIV compared to us. But this, and second is due to lack of in death certificate and all, they'll write HIV only rather than writing HIV tuberculosis.
Documentation is not.
So there is an error in documentation due to which we, like for example, a person dying of TB with HIV will be writing only patient died of HIV rather than writing TB with it.
Students.
My question is to the acne team. What is the normal angle of bifurcation of the trachea?
Very important question forward by you. Which MBBS you are?
Sir, first year. First
year?
Yes, sir.
So the right angle, carina, is more straight.
Yes.
That is why during aspiration, pneumonia, they are more on the right side. And the left is more oblique, sort of vertical. So the cells are less on the left side to aspirate something. Infection will be more on the right side. So also, why more upper lobe or
why there is this primary complex of tuberculosis more into the upper lobe or upper part of the middle lobe of the lungs? Anybody can answer? Yes, aerobic bacteria, ventilation. Second, high oxygen तो से हो गया बेटा, ठीक है ना? Second is the lymphatic drainage, which is less. So chances of the defense are less in the upper lobes. Correct? These are two reasons that you get more of in the upper lobes. ठीक है? ये एंगल वाला क्वेश्चन भी बहुत अच्छा था और अपर लोब में होता है वो भी अच्छा था. एक स्लाइड में किसी बच्चे ने बोला था कि वो लंग है. लंग तो पूरा ही है. It is the alveoli which should have been mentioned. Alright? What is the role of surfactant? That is most important. And if the suppose, should I ask this about the what age of the pregnancy? 28 weeks onwards, नहीं surfactant. क्या होता है surfactant में कौन सा लिपिड होता है? लेसिथिन और स्फिंगोमाइलिन. ठीक है ना? Wonderful, great.
Good afternoon. I have a question for the Department of Pathology. What is the role of interferon gamma in the diagnosis of tuberculosis?
The interferon gamma we can measure the response of the interferon gamma towards the antigens of the tuberculous bacillus which are inoculated in the blood sample, and we detect it using the ELISA. The test is called quantiferon TB gold in tube assay. It is not actually a strictly diagnostic test, but it is used for the screening purpose.
I think it's been a wonderful presentation by all the students, and the credit goes to the students and their moderators. But this is one place which I have learned that our postgraduates should also be present, because the presentation by the UG students was much better than what our resident students.
Another thing is that जितना भी प्रेजेंट किया वो सारी बेटियों ने किया, डॉटर्स ने किया. So you should also come forward and know the things and next time, all right?
It is a benefit also because they've done the basics.
Yeah, exactly, better. But I hope you will be very good doctors. Very much.